Good afternoon, everyone. I'm Mary Ann Joyce, the physician liaison for OHC, and today's lunchtime learning topic is early detection, prevention, and treatment of skin cancer. I have Dr. Partridge here with me. She's our medical oncologist and hematologist who specializes in breast cancer, gynecologic cancer, lung cancer, hematology, as well as melanoma, which is what we're going to be talking about today. So here's Dr. Partridge.
Hi, everybody. Good afternoon, as of 2 minutes ago. So I think this is a good time of year to talk about skin cancer and prevention because of the time of year that's coming. I also think, not to make it political, but there were some statements in the government the last 2 weeks or so where I think talking about skin cancer prevention is appropriate for this. So we will get to this quick little lecture here. So the goal is, what can we do to prevent skin cancer as best we can? And obviously one of our biggest issues is how do we take care of ourselves when we're out in the sun? The other is indoor tanning beds, and this is what I'm referring to in terms of government statements. There's and then trying to help people understand what to look for in your skin, maybe when to call your doctor to be checked out. Whoops, where?
Next slide. Megan's doing it.
Oh, sorry. Okay, sorry. Did not realize this.
Yes.
Okay. So the main thing to try to prevent skin cancer is actually ultraviolet exposure. How much sunscreen or what strength of sunscreen should be used is sometimes a very common question. And for now, we recommend an SPF of 30. I think there's some controversy as to the safety of sunscreen. I think that is misinformation that's being portrayed in areas of social media. So we are very, very much in favor of using sunscreen of an SPF of 30. It is important to try to apply it before you go outside, 15 to 30 minutes, because that'll take time for it to absorb into the skin. And then I think the harder part is remembering to reapply it. I am very much not the best at this myself. For on the beach or at the pool, bringing it in on the beach and putting on you when you have all the sand on you. But that's extremely important to try to remember to reapply every 2 hours, especially if you're swimming or sweating. Besides sunscreen, there is sun protective clothing. There are bathing suits now and even t-shirts and shorts that have SPF protection, which is nice because sometimes you might miss a spot that you can't reach. So I think those are really convenient and helpful to use. Hats are also important. I'm sure some of you, I know I have gotten scalp burns, and that's kind of a hard place to screen for because of our hair. So trying to remember to wear a hat is also, I think, ideal. Time of day to be out in the sun, your strongest sun is usually between 10 and 2. The other important thing is tanning beds and indoor tanning. That's what has come up a little bit recently in the government, where there's discussion of lifting bans on tanning beds. There's a ban now for teens to not be able to be allowed in a tanning bed without parental consent. And that is, of course, to prevent these young people getting melanoma. It's been something that dermatologists has been fighting for and finally got it passed. There was mention in the Department of Health and Human Services to lift that ban, which we think is not a good idea. So just again, the importance of not doing indoor tanning. A lot of girls like to do it when it's the dance time. It's basically putting yourself at the highest risk of getting skin cancer compared to anything else. So to me, tanning beds are what we call a carcinogen. They should be, it's just a terrible idea for your health. So, in terms of who should get screened, there are certain features that may be higher risk. I always said I'm the quintessential risk factor. So if you look at me, I don't know if you guys can see me, but yes, the fair skin, those who have a lot of moles or freckles, blue eyes, family history is also important. Um, People that are on medicine to suppress their immune system, so that can be organ transplant recipients, anybody who's on medication to suppress their immune system, you are higher risk to get skin cancer. And so thus, even if you are somebody who's maybe not at risk appearance wise, if you are immunosuppressed, that does need to be addressed. But even if you're not high risk, skin cancers can occur in areas under the nail or on the sole or palm of the feet. So really anybody should be looking out for this. It's just that certain people are going to be higher risk. Definitely a high risk person should see a dermatologist once a year. I personally go twice a year. I've had a brother and sister get melanoma, so I'm a little bit on the higher radar. An average person, I suppose, doesn't necessarily have to, but I always say if you notice something that seems different to you, to bring it up to at least your primary care doctor. A lot of primary care doctors are comfortable doing some baseline dermatology recommendations. Next. So when we talk about abnormal moles, this is probably something that's somewhat familiar of what to look for if there's a mole on your skin that you're not sure about. The ABCDEs is definitely a thing that we've been stressing over the years of what to look out for. A standing for asymmetry. So if it's not a perfect round shape, if it's irregular, that might put one at higher risk to make something be made aware to their doctor. If the border is irregular or if the edges are blurred, color is important if it's not uniform. So there might be different shades of brown or black, red. If there's a variance there, that's always something to bring up. The size, we always use that pencil eraser size if there's something bigger than that to bring that up. Small ones can be too, though, but size is sometimes an easier thing for people to realize. But again, don't ignore small things either. And then if it's changed, we all have to kind of watch our own skin. I try to check mine once a month. If I think something's different, then, I'm calling my dermatologist to check. So I think that more or less sums up the 5 things that we're looking for. Next slide. And these are just examples of what we just talked about, how on the left column here, you can see the left column is not asymmetric, but the right side is, just to kind of give you an idea of, and some of these are extreme examples, but to get an idea of what the asymmetry of a mole might be, the abnormal border, and then the one on the right side, third one down, you can see some variance of color. And then I think the size thing here is a little bit hard to say in this picture, but again, just emphasizing if it's bigger than a pencil eraser to get it checked. I also tell people if something's bleeding, that should be checked as well. If a mole starts to bleed, that's not really included in this list, but I always encourage that because there is such a thing as an ulcerated melanoma, and sometimes those will bleed. Next. This is just an illustration that not all melanomas appear in places that we think are going to get it. So most of the time it's going to be sun exposed areas, but you also want to check on the palms and soles. This is supposed to represent a sole of a foot, I believe. So anything under on the other surface of the hand or foot, if there's a lesion, that definitely needs to be looked at because that's an abnormal finding. So keep track of those feet and hands. So we can skip over that slide. That's more or less, I just wanted to. So there's different types of melanoma. The first one, superficial spreading, is usually the most common. So it's going to more spread more or less sideways on your skin as opposed to moving down in the skin. Those tend to be maybe the least problematic because what we care most about with melanoma is how deep it goes in your skin, like in the skin layers, not so much across. But again, I think these pictures are also here to just illustrate what they may look like. Okay. These are definitely ones that we see that get exposed, UV light being the biggest exposure. And as mentioned, these do well because superficial spreading, they tend to not go deep into the skin as much. And that's melanoma learns to spread if it goes deeper into the skin. That's why the superficial spreading do better than some of the others. Nodular melanoma is probably the one we get the most concerned about. Because that and the ones that are on the palms and soles, they're not very nice either. But the nodular ones have a tendency to go deeper into the skin. So as you'll see, the prognosis of a nodular melanoma tends to be a bit more aggressive. When people need treatment for these melanomas, it can vary depending on what we find. Most generally, what's going to happen first is the dermatologist is going to biopsy it. And a lot of times after that, you have to see either a surgical oncologist, which is a surgeon that does surgery on cancer patients, or sometimes some of the dermatologists will send people to a Mohs surgeon. That's been sort of a newer thing in the past couple of years. That's most of the time if something's pretty small, because really a surgical oncologist is somebody that needs to take off, once the biopsy's there, oftentimes there's still melanoma left at the site of the biopsy. And based on the size, they have to cut around a certain area around the melanoma so that, it's a fairly big skin defect that happens. And sometimes the melanomas are advanced enough to where they have to do a test called a sentinel lymph node, which is when, similar to breast cancer, if you're aware of what that is, you inject a dye around the site of the melanoma, and the dye that will then travel through the lymphatic system. And the lymph nodes that take up the dye first are what's called the sentinel lymph nodes. That means it's going to capture the cancer first if it decides to move. And a sentinel node is sometimes important if the melanoma is, a fairly big melanoma or more advanced, as lymph node involvement definitely increases your risk of it spreading. And that's when people like myself, medical oncologists, often have to get involved in helping treatment. So sometimes the treatment ends with surgery. If it's lymph node involved, you have to meet a medical oncologist to discuss reduction of relapse. Sometimes if it's lymph node negative but big enough or deep enough, sometimes you have to talk to a medical oncologist after that as well. I bring up this other picture, the amelanotic melanomas, because not all melanomas are dark. So if you have an abnormal new mole that's red, I just also would like to illustrate that that's important to bring to somebody's attention. Okay. And again, these can act a little bit more aggressively as well compared to the superficial spreading. So again, it does get hard to know what's what. And believe me, there's people that come into dermatology offices, and even in my office, because maybe I'm seeing them for something else, they'll ask me, what do you think of this spot on the skin? I would just say, if you're not sure, ask. Nobody expects you to be able to diagnose your own skin cancers. There's a lot of benign moles that look cancerous, so nobody's expecting anybody to be able to figure it out. But the point is not to ignore it. To touch base on some of the other skin cancers, melanoma being the one that's most aggressive and potentially more life-threatening. Two other ones that we tend to talk about are basal cell carcinomas and squamous cells. This picture is just to give an example of what they may look like. They look we kind of describe them as pearly appearing, like they kind of have a sheen to them. They definitely are caused by recurrent sunburns and that sort of thing, or sun exposure. The thing about basal cells is the majority of the time they're very easy to take care of. Surgery is generally all that is needed. I have seen times where patients have ignored these and they've gotten so big that they can't be removed surgically, or they might show up in a strange area of the body, like close to the eye, where they can't always operate. So occasionally I'll see a basal cell cancer patient, because we do have oral medications that can help shrink basal cells down if there's going to be a major cosmetic defect around the eye, or somebody who's ignored it for way too long. You'll have people coming in with like a big bulge off of their head, but that's extremely unusual because of more or less of ignored care, or I guess not seeking care. But generally the prognosis of those are very good. I've never lost a patient to a basal cell cancer. I've had local problems, but usually not life-threatening. Next. So this is just an example of, if people leave these alone, they can be very disfiguring. A lot of times when people get them around the ear, again, around the eye, that could obviously impact your ability to close your lid. So we've had some problems where people, if you can't close your eye, you're going to have corneal ulcers and that sort of thing. And if you leave the ear alone, that can be very disfiguring as well. So we can move on from that. It's just as an illustration of don't leave these alone. Another similar behaving type of skin cancer is squamous cell. What I usually tell people to look out for with these is something that keeps scaling. A lot of times there's a lot of precancerous lesions that will seem to keep scaling, and you'll flick it off and it'll keep scaling back. That's something to bring to the attention. Again, some of these are very simply removed with just an easy, the dermatologist can actually freeze a lot of these precancerous lesions off and you need no further treatment. But we always do say if something keeps scaling and flicking off, to bring that to someone's attention as well. Next. And again, this is just a little bit of you can see why, like if you remember the picture for the basal cell, the squamous cell doesn't look a whole lot different. So again, not something you have to know, just something what you need to bring to somebody's attention. Squamous cells generally, again, if you present them early enough, you're just going to need surgical excision. There's rare times where we can find them in lymph nodes, and then we might be doing things like chemo and radiation. And some patients with squamous cell, there are patients that have multiple squamous cells all throughout their body, and the dermatologist can't keep up with them. So they will sometimes see medical oncologists as well, because a lot of these patients will respond to immune therapy actually very well. Or there's topical creams that some dermatologists will prescribe to try to control some of the early squamous cells or even full squamous cells, but it's not always surgery with these squamous cells. There are times where it's extensive. It's usually an elderly person, honestly, when you have so many that you can't keep up with. Next. I do always like to bring up what to look out for in a nail, because nail melanoma can show up in the nail. So again, this is an obvious example, but just if you see something dark form under your nail, that's important to bring it up. I would take the history to make sure somebody didn't drop something on their toe, because sometimes it's a blood blister. But again, and those can be seen in patients that are that. You can see those in people with darker skin. That's why skin cancer is not just a disease of fair-skinned people. They can happen in all skin color types. Next. Again, just another example. So there you see we have somebody with a darker skin tone with a melanoma in their nail that you wouldn't think would be somebody who would get melanoma. So again, we can't ignore these. We can move on from that. So the big things are make sure you do a monthly skin exam, especially if you're higher risk, light eyes, light skin, you burn easily. If you've had a lot of sunburns as a child, Or, like me, I went to the pool and I was 12 probably from age 6 to 12 every day. So I've always pictured myself as this is what's going to get me, but um, and then again, I can't stress enough about the tanning beds, especially if the government lifts that ban. Please, if you're a parent, do not let your child go to a tanning bed. We're all about turning over in our graves over this, and even though we're not dead, the fact of taking away a tanning bed ban is about the most unhealthy thing that can be done. So just please don't let your children go to tanning beds. We get 25-year-old women with melanomas that can take them from their life, and it's awful. So none of us likes to take care of that situation. It's very sad. And then again, just remembering the ABCDEs of what to look for in abnormal rules, the sunscreen goal of 30 or higher, and trying to stay out of the sun as best you can between 10 and 4. I know realistically that's not going to be every day for everybody, but it's more of a, if it was a constant thing, you really have to be careful and mindful of taking care of your skin. Okay, any questions? All good if not.
I do have a
Okay.
question.
Yes.
This is Teresa. Um, does a higher SPF sunscreen mean that it's better than a 30, like say it's 50 or 70?
Right. There's exceedingly minimal benefit beyond 30. It's really not a huge difference. So I think some of that's marketing. In terms of how much UV protection beyond 30, if you go to 50, there really isn't a huge difference. It's a minimal percentage change. So that's why, if you want to, fine, but you're not getting a huge difference. And so I'm sure that's a marketing ploy. But in any event, I think that's a good question because that comes up a lot.
Okay, thank you.
Mm-hmm.
Dr. Partridge, I have a question as well, kind of regarding sunscreen. I know you kind of touched on this, but there's, normal quote unquote sunscreen and there's mineral sunscreen now.
Yeah.
Is one better than the other? Like, should we be using one more often?
I will tell you my own personal experience as my dermatologist. I went to Hawaii about 2 years ago, and he recommended mineral sunscreen. I think if you're going to be in an area where you're more likely going to be, shall we say, more tropical area. And you're going to be outside probably the entire vacation. My dermatologist did recommend mineral based in those settings. So maybe if we're going to the Caribbean or somewhere where the sun's going to be even stronger, like closer to the equator, or closer to the, where the tropics are, that tends to be something that would be maybe more favored.
Perfect. Thank you.
Mm-hmm.
I have a quick question piggybacking on the different levels of SPF. I have heard people say that the higher the SPF, the less often they need to reapply. Does that have any bearing?
I would call that false. So yeah, that doesn't get you out of it, unfortunately. I know we would all love that. But yeah, no, I can't endorse that.
Good to know. Thank you.
Yeah. Yep.
What about SPF for kids?
Yeah. Usually after the age of 6 months, and you'll have to forgive me, it's been about 25 years since I've done any pediatrics, but generally 6 months and above is when we need to be thinking about sunscreen. And if they're under 6 months, I believe most pediatricians would discourage a lot of exposure. So if you're taking a young baby out in the sun like that, I think it's a matter of, what can you do to keep them covered with hats and that sort of thing? Because I believe they don't love sunscreen in babies under the age of 6 months. And, if I'm incorrect on that, I apologize. But I'm almost certain 6 months and above is when they recommend you start doing sunscreen.
And what about kids like 6, 7, 8, 10 years old?
Same,
Still
no
30?
change. Yes.
Okay. Thank you.
Yes. Mm-hmm. All
All
right.
right, thank you so much. I appreciate it. This recording will be sent out to everyone that registered. So thanks again for joining us for this month's Lunchtime Learning. Have a great rest of your day.
Thanks, everybody. Have a
Thank
good
you.
day. Okay.
Thank you.
Thanks. All right.